Welcome to today's webinar, Leading Transformation to a Patient-Centered Medical Home. My name is Melissa De Silva, and I'll be acting as your moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council, made possible by a grant from the Health Resources and Services Administration, Bureau of Primary Health Care. Today's webinar is a 1-hour presentation, and we will have the last 10 minutes of this hour reserved for questions and answers. Please type your questions into the chat box below the slide at any point throughout the presentation, and we will get to as many questions as possible in the last 15 minutes of the hour, 10 or 15 minutes of the hour. Today's webinar, Leading Transformation to a Patient-Centered Medical Home, is one in a series of webinar productions by the Council for HCH grantees on PCMH recognition, designation, and accreditation, and achievement of meaningful use. So please check our website for a ton more information on this topic. Today's presenters are our amazing consultant, Anna Gard. Anna is a certified family nurse practitioner and has been in clinical practice for 17 years. She's a team clinician for the VNA Community Health Services Children's Clinic, a Level 2 NCQA PCMH nurse-managed safety net health center. She works as the Health Disparities Consultant for Association of Clinicians for the Underserved, ACU, providing TA to special populations including National Center for Health and Public Housing and, of course, the Council. Her key areas of focus are the intersection of health disparities, quality improvement performance, patient-centered medical home, chronic care management, and health IT in safety net populations. Our second presenter is Dr. Parminder Bajwa. Dr. Bajwa is the Director of Medical Services at the Columbus Neighborhood Health Center in Columbus, Ohio. Dr. Bajwa loves all things QI and has been featured in a couple of other council productions. She will also be a part of our Pre-Conference Institute on Leadership in DC in March 2013. So check back for more information about that in a couple of weeks. Dr. Bajwa is the Director of Quality Improvement and Risk Management at the Columbus HCH. She brings over 20 years of experience to her position there and has designed and implemented programs in leadership and mentoring, as well as quality improvement for pediatric residents. You are all about to experience an amazing presentation by our two wonderful presenters who've been working with HCH providers specifically for the last 2.5 years. So I am pleased to now turn the mic over to our first presenter, Anna Gard.
Good afternoon, everyone. Thank you for such a glowing introduction. I hope I can live up to that. And thank you for logging in and spending some time with us this afternoon. Today we are going to start our webinar with a very brief poll. If you could look at your screen, the question is your health center recognized, designated, or accredited as a PCMH? If we can spend about 10 seconds while you complete that poll. Okay, leading transformation to a patient-centered medical home. It looks like those of us on the call, we have about 83% of listeners are not yet recognized, designated, or accredited. 16% are. So we are all in the beginning processes, and we'll really value the expertise of Dr. Bajwa as she speaks about her own organization's transformation to NCQA recognition of patient-centered medical home. Just to let you know that HRSA is strongly encouraging all health centers, particularly HRSA-supported health centers, to get patient-centered medical home recognition. And there are 3 current organizations: the Accreditation Association for Ambulatory Health Care, which would provide an accreditation, and that's part of their overall accreditation. The Joint Commission, which has always been excellent at evaluating the fundamentals of clinical quality, particularly when it comes to things like lab testing, infection control, patient safety, and clinical competence. They have a secondary designation for patient-centered medical home. And then NCQA, which really focuses more on access to care, patient-centered care, care coordination, population health management. The NCQA recognition process and their 6 standards is very closely aligned with the electronic medical record meaningful use standards, and NCQA recognition is very visible in the medical home world, particularly to third-party payers. This is something definitely you should investigate in your own state, but HRSA has a comparison chart on their website of the 3 different organizations for patient-centered medical home recognition, and the council also has more extensive resources in the patient-centered medical home resource catalog, which will provide the link for you at the end of this webinar. So moving forward, the NCQA patient-centered medical home has 6 standards of care, which are listed in these bubbles. Access, really, we define access as looking at what kind of availability do you have to meet your patient's needs at any given time. That means 24/7 access to health care services, including on-call availability. Do you provide your health services in a language that your patients understand? Do you have your patients assigned to a personal primary health care team? Another term for that is considered empanelment. And what kind of appointment availability do you have? Do you have open access scheduling? Do you use outreach? Do you have a mobile clinic to meet your patients where they are? Population management is looking at how are you focusing on particular population. And that means, can you pull up lists of diabetic patients? Do you have registries? Can you document problem lists, allergy lists, medication lists? Can you identify populations based on their demographics, their smoking status? So how are you providing care and looking at population health management? Planning and managing care. That is really, do you have the capability to start identifying your high-risk patients? Can you stratify them? Looking at patients with complex comorbidities, which is the majority of our patients in the HCH world. Can you identify your patients who have comorbid mental health or substance abuse issues? How are you planning and managing their care, because it tends to be a little bit more complex and labor-intensive? Are you able to integrate evidence-based guidelines and clinical decision support into your care management processes? And are you providing individualized care plans for each of your patients, including medication management? And how do you document that, and what are your processes for that? Because those are all things that need to be submitted in your NCQA patient-centered medical home application. So a lot of that planning and managing care is a real focus on chronic disease management, using protocols, as I said, evidence-based guidelines, clinical decision support. And are you using point-of-care reminders to prompt clinicians on preventive services and chronic disease management services due? Do you have prompts for mammograms, colonoscopy, lipid screening? Are you using standing orders? Self-care and community resources, and I think this is something that is inherent in HCH care, is that we already recognize a need to empower our patients, to motivate our patients, to use skills like motivational interviewing to try and engage our patients in their care. So this is something that really is inherent in HCH care. Tracking and coordinating care, and this can be a challenge with our population. How do we facilitate transitions of care between settings, from the ER to the health center, from the hospital to respite care? How do we communicate a patient's records? How do we make sure that there's that, what we call that warm handoff between clinicians, so that our patients are not just showing up in multiple ERs with no history or information with them? Are we using any kind of care coordination model where we use health navigators or social workers? Do we use something called Healthy Leads, which is an organization of volunteers that helps set up community resources and facilitate enrollment into public benefit programs? Enabling services are really the key to support this model in HCH care, particularly with tracking and coordinating care. Having on-site pharmacy and lab services, WIC services, housing services, outreach and transportation, all at the health center so that we can support our patients as we try and coordinate their care. And then how do we measure and improve performance? What kind of quality improvement initiatives and how do we measure that? And Dr. Bajwa can speak to that in her own experience with her organization about tracking how well we're doing and what we need to do better. This is a bit of a busy slide, but I just like to show how the patient is in the center. And if you look, you'll see all of the different providers who touch a patient, and this can be even in just one encounter. You have your clinical assistant who's taking the vitals and doing the assessment. You have your nurse who may be doing medication management and reviewing referrals and patient self-management. Your care manager who's really helping to support the self-management, the clinical management and goals of the patient with their disease management. And then you have the medical provider who's doing the clinical assessment, the evaluation, and the treatment. You have pharmacy specialists, dietitians, behavioral health, and external labs. How are we making sure that all of those people who are impacting a patient's care and impacting their plan of care, how are we making sure that they're all communicating not only with each other, like the hub of a wheel, but also making sure that the patient is in the center and keeping them involved and engaged in their care? What are the particular challenges in the HCH population? As HCH clinicians and administrators, none of this will be new to you, but some of our particular challenges are identification and management of mental illness, addiction, cognitive dysfunction, which complicates their medical illnesses. Management of transitions of care, particularly when you have a very transitory population. Care coordination and team-based care. Much of that can be because maybe you have a lot of part-time clinicians or volunteer clinicians, so you may not particularly have patients assigned to one clinician, so maintaining continuity of care can be a challenge. Complex comorbidities in general are much more prevalent in the HCH population and make for a more complex healthcare delivery challenges. And pharmacologic management, not only the fact that our patients have complex comorbidities, which often dictates many more medications, but how do we assist our patients in not only accessing those medications, but adhering to taking the medications as they are prescribed. Patient engagement. Again, as I said, I think that HCH care is really very focused on this. This is not a new concept in HCH care, but I like to think about patient engagement as moving from the question of what's the matter with you when speaking to a patient to what matters to you. What is it that's important to the patient? How do we engage them in their care? What are our strategies to empower our consumers to be engaged partners in their health care? There are 3 A's you can think about. Access. Are we getting information into the hands of our patients and caregivers, and how are we doing that? Are we doing it in a way that is at a low health literacy level that our patients can understand? Is it in a language that they speak? What is the action? Engaging consumers to actually use that information we provide them in order to improve their own health. And attitudes. How access and action can help shift attitudes about the traditional roles of patients and providers, that it's no longer the provider telling the patient what to do, but working where the patient is in the center and the patient is engaged, and it's much more of a team-based relationship. So as I mentioned, ways to support patient engagement are focusing on providing patients with low literacy, culturally sensitive education, using handouts, videos that are linked to patients' diagnosis, Many electronic health records have e-education materials now that are embedded in their software. You can also embed some low literacy videos in the software so that while the patient is sitting in an exam room, those videos can be brought up during the course of a visit with either the care manager or the nurse to help with self-management and patient engagement. And also providing patients at the end of their visit with after-visit summaries. An after-visit summary is a meaningful use core requirement, and it is a summary of a visit which lists medications, the diagnosis the patient was seen for, perhaps their problem list, and any office contact information, pharmacy information. These summaries need to be provided to a patient in simple, understandable, basic language. And this sometimes can be a challenge for HCH sites because if the mobile van or they're doing outreach, they may not have access to printing capabilities for an after-visit summary. If portable printers are not an option, considering using web-based patient portals. There's some websites called Health Shack or Mivia, which are specifically designed for homeless and migrant populations, and also using patient portals, which is a part of an electronic medical record where patients can log into their own health record and view their after-visit summary. Again, the challenge is resources for our patient population to have Internet access, which can be accessible through Internet cafes, libraries, some shelters, but it may also mean in your health center setting up a computer kiosk within the health center where patients can access the portal there. So also thinking about in patient engagement, how to utilize mobile health technology to support outreach, chronic disease management, appointment reminders, and test result follow-ups. There are some really interesting pilot programs right now called Text for Health that HRSA is supporting. So far they have some programs on smoking cessation, diabetes, and pregnancy. But thinking about how do we use technology to engage our patients and help them with their management. So opportunities through use of health information technology, and particularly meaningful use of health information technology, improving quality and safety by integrating clinical decision support within the electronic health record, which will help prompt clinicians on preventive services due, on last lab results, prompting when mammograms are due. Also engaging patients and families, as I had mentioned, using technologies, patient portals, even sitting down with a patient in front of the screen and being able to map out and graph blood pressure readings with weight and medication adherence. And often you can sit with a patient and show them that when they were taking their medication regularly, you can show them a graph of their blood pressure being well controlled, and when they stopped taking their medication, that the blood pressure goes out of control. And oftentimes using a graph visual can be very impactful in having our patients understand what's going on and why taking their medication really does make a difference. And using health information technology to improve population public health. And that means we can run reports on all our patients with diabetes or all our patients who smoke, and then we can start impacting programs focused specifically on maybe some of our higher risk patients with chronic diseases. And just to note that those who have already adopted or thinking about adopting electronic medical record and attesting to meaningful use, that as I mentioned before, particularly NCQA, patient-centered medical home standards, are very closely aligned with meaningful use. And in fact, 100% of meaningful use stage 1 is incorporated into the NCQA patient-centered medical home standards. And so that if you look at this slide, which I have to say I borrowed from the Regional Extension Center of the Michigan providers, is that if you're in the beginning of your patient-centered medical home journey and you don't have any technology yet in place, Meaningful use can be that jump start because we know that there's an incentive program to adopt, implement, or upgrade your electronic health record, which provides some incentive funds to get started. If you're designated but you don't have your technology fully in place, meaningful use can really help you understand the technology you've invested in. And if you are already patient-centered medical home designated, which we only have a few here on the call, meaningful use can really help you investigate how to maximize the technology you have to achieve further efficiencies and improve quality in your practices that are so critical to patient-centered medical home. So alignment with your organizational priorities is a great place to start. And this is also a busy slide which I borrowed from one of our workshops at, I believe it was the national conference. Actually, it wasn't an HCH conference. It was the Institute for Healthcare Improvement, the University of North Carolina Health System. And this slide just shows you how this organization set up their alignment, where they listed all the patient-centered medical home 2011 standards and how they aligned with the meaningful use standards. And in this case, they were also aligning with the PQRI standards and JCHO because it's a larger hospital system. By aligning all those standards, rather than sort of reduplicating yourself, you can look at the crosswalk, and that will help with your organizational priorities to sort of jump into the low-hanging fruit, so to speak. I would like to point out that the Safety Net Medical Home Initiative, which is a 5-year demonstration project designed to help 65 community health centers in 5 different states transform into the patient-centered medical home, and I believe they may be at the 3rd or 4th year already, have put together a compilation of tools, archived webinars, and issues of the Medical Home Digest that are available on their website. These implementation guides are incredibly helpful because based on this demonstration project, they've come up with the 8 transformation strategies that are necessary in order to attain patient-centered medical home recognition. And as you see listed here, empanelment, as I said, is making sure that you have patients assigned to a particular provider or a provider health team. Team-based care, because it no longer can one clinician take care of a group of patients, that it really requires, in order for us to support our patients in the complex health delivery system, we need an entire team, and that is your outreach worker, your care coordinator, your clinician, your nurse, your medical assistant, your behavioral health therapist. So how do you create a team that cares for a patient? Because that's somewhat of a newer model than the traditional medical model. Engaged leadership, you see on the slide, I have highlighted it as red because that is really the foundation of transformation, that if your leaders are not engaged and participating in this process and supporting this process, it can't be done. And Dr. Bajwa will really speak specifically about how leadership is inherent in the transformation process. So I just wanted to highlight those guidelines. I would strongly suggest you go to their website. They just released their Fall Medical Home Digest, which has an entire compendium of articles specific to vulnerable population, and I haven't had a chance yet to read it because it just popped into my email box yesterday, but they have a specific case study with healthcare for the homeless population. So I would strongly suggest that you investigate this medical home initiative because they've come up with some really wonderful tools. And lastly, before I hand it over to Dr. Bajwa, I wanted to show this slide, which I did also borrow from the Safety Net Medical Home Initiative, which is a joint venture of Qualis Health and WIREC, which is the REC in Washington State. And this really shows how the 8 transformation strategies lead to patient-centered medical home transformation. And if you look at laying the foundation, as I mentioned, it's leadership. It's engaged leadership. And aligning and having your leadership help facilitate the quality improvement strategy. And setting the stage for that doesn't require any health information technology. It is human activity. It is leaders who say, let's get in the trenches, let's really drive this process to lead the culture change and really support quality improvement. And then the next step is impanelment, and that is supporting the assigning patients to providers or healthcare teams to take care of patients so that we don't have an issue with continuity of care. And we know when a patient may show up at 5 different health centers, 5 different ERs, have to tell their story over and over again, things are left out, history is dropped, medications and tests are duplicated. So impanelment and team-based relationships, which I've already mentioned. Again, it starts to require some health information technology, and typically that has to do with your practice management system. And then moving to the last 4 transformation strategies is change care delivery, that shifting from that traditional model to really focusing on going back to that slide where the patient is the hub of the wheel, is patient-centered interactions, and integrating organized evidence-based care using health information technology for clinical decision support, enhanced access, looking at how are we meeting our patients where they are. Does that mean changing our scheduling, having open access, using more outreach, investing in a mobile van, changing our hours, and care coordination. And that's a big piece and often means shifting of job descriptions and roles, and sometimes means hiring a new role, which can be a nurse care manager who really takes the most complex, high-risk patients and really helps support that coordination of care as we try and align referrals and specialists and treatment with the behavioral health providers and respite care and ER visits and hospital discharge papers and reconciliation of medications. So this is just a schematic of how to integrate those transformation strategies, and the most important is laying that foundation. And so what I'd like to do, since I did an introductory of patient-centered medical home, is I'd like to hand it over to Dr. Bajwa, who can speak about her specific experience in her organization of going through the transformation process. So I'm happy to welcome Dr. Bajwa as she tells us about Columbus Neighborhood Health Center. Dr. Bajwa?
Thank you so much, Anna. This was a wonderful presentation. I thoroughly enjoyed that. Well, and good afternoon, everyone. Thank you for giving me this opportunity. And today I'll be sharing with you all our journey to successful implementation of patient-centered medical home and achieving level 3 NCQA recognition. So I'm going to start with the first slide. That's the mission of our statement, the mission statement of CNHC. And it's to serve the community through services that improve the health of families, including people experiencing financial, social, or cultural barriers to healthcare. So our organization, our motive is not to turn any patient away. We have, these are our clinical sites. We have spread them all over Columbus. And the bottom 2 are new clinics, Mary Haven and CNHC at Columbus Public Health. Here are our CNHC demographics. We have 1,702 homeless population, which we had in 2011. Then we have public housing, 3,591, non-homeless, 20,880. So that's our demographics. Patient-centered medical home principles. Patient-centered medical home concept is a very big concept. So sharing it with the providers, the whole concept, and getting them educated and running over it was kind of very difficult. So we narrowed down the concept into 4 or 5 points, which could be easy to convey and easy for medical assistants who will be assisting them in the process to understand, for nurses to understand, and that's how we went. We picked up, what does it mean? It's one-stop service center for all medical needs. Then it is a continuity of care with the same provider. When a patient schedules an appointment, so we try to have the patient be seen by the same physician. We have the same-day appointments on our provider schedules so that whenever a patient walks in, they should be able to be seen on the same day. Above all is the quality care. This is a slide which I like to share with everyone. When we started our patient-centered medical home, this is a slide which I shared with our board members, our front desk staff, with our nurses, everybody. It is a very, very simple slide. The bottom line is, how can you invest $2 to save $10? And that seemed very attractive, and this slide has been very helpful. So whenever any of you are moving on to the patient-centered medical home concept, I think using this slide is going to be very helpful. A little bit about our implementation steps. So understanding the patient-centered medical home concept, followed by motivation and commitment to change. So our concept is more about commitment to change. So when we share this concept with our physicians, with our nurse practitioners, it was more focused on that there'll be a change in the style of practice. The second one is the time demands of patient-centered medical home implementation. We wanted to define the time frame for the project. For example, we started our meetings in November, and we wanted to start our work by January. So we used the 2 months to build our education platform with our physicians, nurse practitioners, our medical assistants, our nurses. So we were just building up teams, educating them, so that from January we will start the process. We had designated individuals to become the PCMH experts. So for each center, we picked up a couple people who would be constantly educating the staff about PCMH. They would be attending the education sessions. Whatever they learn, they will bring it back and implement it. We kept having regular meetings to evaluate how our implementation progress is going on. We used to conduct monthly meetings to see whether we are moving along the target or we are lagging behind. If we are lagging behind, what is it that's causing the lag? Of course, as Anna has already mentioned, EHR is very important, using technology to enhance patient experiences. This is our process timeline. As I mentioned, we introduced our concept in November 2010, and in January of 2011, we started working with the basic work. We started with identification of 3 conditions. We took hypertension, diabetes, and hyperlipidemia. We pulled out the basic platform after the initial audits, where we stand in in those 3 diagnoses. We evaluated the current policies compared to the NCQA criteria and current treatment guidelines. So I have highlighted few pieces what we did in January, but there are others as well, but these are the few which we did before we moved into February. Similarly, we did in February policies which we were to be developed on access and communication. We identified a practice lead. Practice lead is the same person who is a PCMH expert as well. So that person keeps everybody on task, and also will see that the tasks which are assigned in month of February should be completed in February, and then that's how when we start in March, so there'll be March tasks to be done in March. So we had every month assigned like that. So this is a kind of a detailed slide. So our plan was to finish everything by June, our process to submit by June, but somehow there was some kind of organizational little bit changes, so we didn't submit in June. We ended up submitting in July, which was fairly good. So and we all love the June slide because in the end it says after the hard work, load the documents to the survey tool for submission. So and I just wanted to share this about our clinical indicators that we track for patient-centered medical home. The clinical having a QI plan is very important. We have a very robust QI plan. We evaluate our clinical indicators every quarter, and then we have our annual report every year. So this just speaks about one of our immunizations, geriatric immunizations, that in 2009 we were at 5%. We moved up to 39% in 2010, and in 2011 we moved to 59. So this just shows about the growth, how rigorously we follow our QI plan, and we pull the reports and we share it with everybody. Okay, this is very interesting. These are just a small list of barriers which we encountered. First and most important, as Anna has mentioned, communication and leadership involvement. Communication is important. The first time when we shared this, people did not, the staff members, they did not take it seriously. It seemed to me that it was okay, it's another task. There was lack of understanding, and they did not understand the bigger picture. The time involvement. We implemented in PCMH in 2011, but in 2010 we had EHR implemented in our organization. The productivity was low, and EHR blues, of course, every provider faced it. So they were not ready to move into PCMH the following year. So the time involvement for each physician is about 10 hours per month. So to see the productivity move up and then have PCMH was a big task. It was a big uphill task. Inadequacy was one of the other barrier which we faced. People would worry over meeting new goals and expectations. Policy changes. They were not happy with the same-day appointments. They were not happy that our schedule is open, so they were worried that anybody who walks in, then they will have to see maybe it's end of the day, or however their schedule is full already. So that was kind of a fear. Introduction of new protocols, processes, and job descriptions. Especially with job descriptions, I would like to highlight here the medical assistant job description. It changed a lot, and so there was a fear in that. There was resistance to collaboration between the departments, collaboration between, for example, to work through family practice and social workers, to collaborate, for social workers to collaborate outside CNHC. There was resistance. Of course, the next one is commonly seen, fear, wanting to avoid the unknown. Control. We all know what personal agendas, and that happens. Inconsistency. This is how the staff members understand the medical home philosophy, adopt the patient-centered processes, and present the patient-centered medical home message to each other and beyond the practice. This was very interesting, which I saw was very commonly shared, especially between the nurses, the health center administrators, how they felt everybody understood what they wanted to understand, and there was no consistency of where the organization is moving forward and what actually this message is and what we are taking out of it. So they took whatever the pieces they liked. So there was a lot of inconsistency in understanding this. Solutions. Education on PCMH to leadership and knowledge gaps. We started with educating our board members. We started with educating our executive team. So from there, after they understood the concept, they learned it, we started moving forward. Introduction to physicians and nurse practitioners. It happened in multiple meetings and groups. First, the information was shared as a whole, as a big group. Then it was just a very basic information. The second meeting was held where only the providers were there, where they could ask questions, and there was a good session of questions and answers, I would say. Followed by there were meetings in all the health centers separately with the staff, where there'll be 2 or 3 physicians with nurse practitioners and the medical assistants and LPNs and RNs. So the meetings started from bigger to smaller and smaller, and it continued over a period of time. So in meetings, there was, of course, as we all know, a negative criticism, but in meetings we redirected the negativity and criticism, kept the team process moving forward. There was always an active inclusion of supporting individuals to show them the success that we are moving forward. To help our physicians and nurse practitioners, we created new evidence-based guidelines, and that's how that was extremely helpful even for the nurses to assist the clinicians in their practice. With help of EHR, we were able to pull the reminders and for preventative measures. Similarly, after visit summary for our patients is very, very important. As Anna had mentioned, the after visit summary which has the details of the visit plus medications, next visit, and also if the patients are having scheduled any appointments with the social worker or pharmacist. Creating a patient-centered care process. Patient comes first. We always talk about patient comes first, but what we insisted here was whatever we talk should be presented in the actions. So everything is for patient. leadership development and dynamics of team approach care. I have already mentioned about it, but still it was an approach there we would positively move forward with support of leadership, and people would to be followed. Use of data, culture change, enable practice transformation. As I've mentioned before, we have the QI report. Every quarter it comes. So the RQI coordinator made it a point that she would share the QI reports at every health center, at each of their staff meetings regularly, religiously. So people learned that this QI report is coming. Then we started comparing the reports with one health center to the other health center. So nobody wanted to fall below the line. So everybody was working hard for that, which was very positive. Here, this is another slide, just a brief summary of our success here. Extended awareness for the board members, the leadership team, and clinical staff. This is a key, and majority of the time was spent on this, but it was not, we shared it at regular intervals. It wasn't that we shared right from once and then forgot it for next couple months. It was regular, every month, every meeting, and everywhere. It was constant, and it is still continuing that way. Prioritizing the tasks. Following the deadlines on monthly basis, that's another thing. We had post-its, and we had some charts. We had, on the data walls, we had descriptions which would say our tasks for this month. So the staff at health centers, they followed that each and would mark, cross out whatever task they had done. And they would like to finish every task by 30th, at least by 30th of the month, so that because they knew that next month would have another task. Team members are well versed with EHR, though it was a short time, but still they educated themselves, and they knew how they have to navigate through EHR to pull the preventative measures and help our providers. They're just to put a little tickler that the immunizations are being missed or any preventative measure is being missed. About the robust QI plan, I've already talked about it. So, and there's another point, there's patient satisfaction surveys. We do have patient satisfaction surveys conducted every year, and the data is compiled. We share it from, I think we have a data from last 4 years. From 2007 or 2008, we have data compiled, and we share it with everyone, right from the front desk to the nurses and back to the providers. This patient satisfaction surveys are also shared in our board meetings, so everybody's on the same page with the patient satisfaction surveys. These are our next steps, which after our initial implementation, these are the next steps which we are working on. Care coordination is a big thing. We haven't done so much of care coordination, and we are developing this area. We have worked to implement 2 processes. One is huddle process, and one is referral management. Those are the 2 big things which came up, which were very important for us to carry on the care coordination. So huddle process is when the physicians and their MAs, they will meet every day to go over their schedule for next day. So the meeting usually lasts about 10 to 12 minutes, and they will go over the patients who are scheduled for the following day to see what the patient needs and why the patient is here, and to prepare a better day, better following day. That's the best way to say. So that has helped a lot. And referral process is another big thing which we are tackling. It's still growing, and we haven't fully accomplished it. But there is a specified process which our physicians and our MAs are working together. And if there is a level 1 referral, means the MA will make immediate attempts to get the referral and get the results back to into the clinic. The second group of referral is where it's in non-urgent, but still it needs to be received quickly. So there's a gap period of 1 week. So within 1 week they can get that result back and can be addressed. And third group is where which the referral is when the patient comes for the following visit, that result should be there. So those are little steps which are organized into our organization, which we have done to improve care coordination. Patient Navigation Center. This is whenever a patient calls in our clinic, the message doesn't go to a voicemail. They talk to live body. We have customer service representatives who are housed in one of our clinic, and they take calls for all our whole of CNHC. Our front desk staff does not have phones. They have one-to-one interaction with the patients, so they don't take any phone calls. They don't have phones available at the front desk. So all the phone calls, they go to the customer, to the Patient Navigation Center. This is to eliminate barriers to care, to ensure patients get the follow-up appointments and can access the needed services. Also to ensure timely delivery of services, to assist patients in moving through the healthcare system as needed in a timely manner. Modified open access. For our providers on our schedules, we have put 12% of same-day appointments, and we have looked into our walk-ins, and we have looked into our no-show rates. So for 1 year, we have measured our data. Based on that, per provider has an open schedule. So for example, in one of our clinics, the no-show rate is high, but we have high walk-ins. So the scheduled appointments are very, very less. There are about 4 or 5, and the rest is open schedule. So as the patients come in, they know they will be seen on the same day. At one of our clinics, there is no modified open access because the patients, they all come in time, and they want a proper scheduled appointment before, and so nobody walks in. So that's the kind of a work we have done with behind the scenes to go over it. So each provider has a different variation depending on what the data showed. And so it has a variation on their schedules. Continuity preserved since the primary care physician has daily open appointments. We've talked about that. Medication therapy management. This is very interesting, and it is new for our clinic. We have recently got a full-time pharmacist to address this. So the full-time pharmacist will be meeting with our providers, with our physician, with our patients, and to manage the chronic diseases and handle that difficult population, and to get their outcomes in a controlled panel. So that's what we are working on it. So these are our we have just basically started very little of it, I would say we have started, but hopefully as we move forward into the next year, so we will grow on it. Yeah, that's it. Thank you so much, and over to you, Melissa. Thanks.
Thank you so much, Anna Gard, for laying, I guess, setting the stage for today's production on patient-centered medical home. And thank you, Dr. Bajwa, for that excellent, I guess, mini case study on the role of leadership in implementing a strategy for PCMH recognition. We have 3 questions. 2 of them are related, and they're all for Dr. Bajwa. So let's see if I can do this. The 2 related questions. How did you actually get buy-in from staff who already feel overworked and burdened? And I guess related to that, can you talk a little bit more about how you communicated purpose and value primarily to the clinical staff? Dr. Bajwa?
Thank you so much, Melissa, for that. That's our first 2 big barriers we had. The first one, when we first met, we got the at a leadership at the leadership team level. We made it. Everybody understood and made it a commitment that we will move forward on this. This basically was our CEO's idea and his concept. He shared it with me, and then it's like one-to-one how we spread it. So I shared it with Director of Operations. So 3 of us got together. We talked to the rest of the executive team, and they felt that this was important and it is good. And it was now the mountainous task to share it with the providers. And they are, of course, they are burdened. So what we did is we started working behind the scenes to tackle the issues where the providers will be helped. So the provider support is very important. We have 3 medical assistants for 2 providers, like a physician and a nurse practitioner. So we grouped them together and we provided them 3 medical assistants. The medical assistants started receiving training about patient-centered medical home and their job duties and responsibilities in separately from the providers, from the physicians and nurse practitioners. So they started working on it. On the other side, when we shared with the providers, they wanted some, it was very open and a frank discussion that we are moving forward for it. So let's tackle what the barriers are. Let's tackle what your concerns are. So that's how we started doing. And then there was some of the providers they wanted a nurse component to help their practice. So we grouped 2 and 4 providers, like 2 physicians and 2 nurse practitioners together, and provided them 1 LPN who could manage their cases and to take some loads off of the clinic load and help the patients around that. So those are the things we provided. We provided them clinical guidelines, and then in our communications, in our monthly meetings, in our staff meetings, it was made it very clear that regardless of the negativity and criticism about overwork and everything, we will still be moving forward. So, and it wasn't a very strong approach. It was, but on the same end, it was very well supported on the needs, what they wanted, what the physicians and nurse practitioners wanted the clinics to go on. So they were very well supported on that piece as well. I hope that answered the question.
Thank you so much, Dr. Bajwa. You also touched a little bit on the third question that came in regarding how you revised the medical assistant's job description. And what I'd like to offer our participants is that we will post a copy of that revised job description with this archived webinar. So for those of you, and most of you are brand new to the PCMH recognition process, please know that we have several case studies on this process archived on our website at www.nhchc.org. If you get lost navigating our site, please don't hesitate to call staff and we will get you to the resource you're looking for. We will have a couple other webinars coming up in this area of PCMH and meaningful use at the end of January and early February of next year. And we will have several workshops at our national conference and then regional trainings in March and May respectively. So I'd like to thank again our amazing presenters, Anna Gard, who is also a consultant on all things PCMH and meaningful use for the Council, and our amazing grantee, Dr. Parminder Bajwa, who will continue to support all of our efforts in helping HCH grantees achieve recognition, accreditation, designation. So thank you all again. Sorry we went over by a minute. Have a terrific day.